At Five Star Bank, community is at the heart of what we do. Every day we strive to have thoughtful solutions for our customers and help our communities prosper. Honest dialogue about the issues affecting the region is vitally important to that prosperity. We are proud to be part of the conversation and hope you'll join in.
Cancer. The word has the power to stop any conversation at its mere mention. Its impact touches every part of society, and its mark can leave devastation and despair in its wake. A new documentary presented by Ken Burns, The Emperor of All Maladies, takes a historical look at cancer with a focus on patient stories and scientific progress through the decades. Joining us today on Studio Sacramento to help us understand the war on cancer and the progress we've made are Dr. Rafe DeVere White of the UC Davis Comprehensive Cancer Center and Dr. Mack Roach, Medical Scientific Officer for the American Cancer Society. Dr. DeVere White, why does the mere mention of cancer stop us all in our tracks?
Because we are worried that we will die of it, because we're worried we will die in pain, because we're worried we will lose our dignity when we die, and because we're worried about the effect it's going to have on our families.
Dr. Roach, when patients come to see you in the work that you've done over the years, what's the number one thing on their mind?
Well, if it's the patient who has a cancer that involves, for example, the prostate, they're worried about their continence, they're worried about their sexual function, they're worried about their sense of manliness, they're worried about how people will perceive them, they're worried about the impact on their socioeconomic status, their job. There are many factors that are involved. In some patients, if the cancer involves the head and neck, they may be very concerned about their appearance. If it's a woman with breast cancer, she may be worried about losing hair.
How many people in our society does cancer affect? How broad is its impact?
This is huge. Somewhere on the order of 1 in 4 people will get cancer in their lifetime. So all of us have family members who have had cancer, and when you're in a room with people and you're looking around, you can realize how many people are going to be getting cancer.
But are we overly worried today with all of the progression of treatments? Is cancer becoming a bit like HIV in that it's becoming more of a chronic illness to be managed rather than just a death sentence outright?
Well, it's certainly not a death sentence. I mean, there are 14.5 million Americans who are surviving. In 1971, we had about 1 in 69 Americans who were survivors. It's now 1 in 22. So it certainly is not a death sentence. But on the other hand, we are nowhere near making this a chronic disease. And the real reason is there's 40 million Americans over the age of 65, and about 390,000 died last year of cancer. In less than 15 years, we will have at least 74 million Americans over the age of 65. And if we do not do a better job of treating advanced disease, over 700,000 of them will die. So we hope to make it a chronic disease. We have not made it a chronic disease.
It's been said that this is a disease of aging.
Yes.
Where does that statement come from?
Well, first of all, half the cancers diagnosed are in people over the age of 65. And the problem is that cancer comes from inside. Cancer comes when the machinery of the cell goes wrong. And it is going wrong and repairing all the time. So it's like you accumulate these hits as you go along. And because we've done such a huge job in lowering the mortality from heart disease, we are living longer, which is great, but more of us are going to get cancer.
The studies and research that's going on today, what's different in our era today in terms of options and hope to be able to prolong life or cure cancer than was here, say, 10 years ago?
Well, I'm going to answer that question, but I wanted to get back to that question you raised about HIV and cancer.
Let's go.
You know, most people who are, you know, in a monogamous relationship, married, they're not worried about getting HIV. I mean, to get HIV, you have to be exposed to the virus. The thing about cancer is the cancer doesn't spare anybody. You can be a vegetarian, you can be a non-smoker, you can have no family history, you don't have to be exposed. We don't know why everybody gets cancer. There's certain things that are preventable, but even if you don't do bad things to yourself, there's a good chance that you're going to get cancer if you live long enough. And coming back to the point that was made, is that we think it has something to do with immune surveillance.
Well, wait a minute. Okay, I got to stop you for just a second, Dr. Roach.
Mm-hmm.
So we are bombarded every single day with media advisories and public service announcements and things like that, that if we just change our lifestyle, if we eat healthier, lose weight, have a sunnier disposition, that we can hold back cancer. What you're saying is that may not necessarily be so?
Well, no, you can reduce the probability that you get certain cancers by doing certain things. You could also make sure that if you do get the cancer, that you get it diagnosed at a point where it can be cured. Eventually.
So in other words, you're not giving me license to go out and eat
No.
lots of fatty foods and
No.
Okay.
No. In fact, we know that if you don't smoke and you're not obese and you do the appropriate screening test that you should do, then you have an excellent chance of reducing the likelihood that you die of cancer, but you don't eliminate it completely.
Dr. Roach opens an interesting door, Dr. Vere White, about screening and getting seen. What impact has recent health reform had, or what impact do you perceive that it'll have in maybe getting more people in the door? Is there a relationship between getting people in the door and getting screened and getting regular care and attacking this disease?
There absolutely is. If we look at that increasing death rate, one of the ways that we can try and stop this is, first of all, eliminating cancer health disparities. This is where we actually know what to do, and for whatever reason, people don't avail of it.
Pause with me for just a second and tell me what cancer health disparities are and who they impact.
Well, so you could have it because you can't get access to health care. For instance, Asian Americans have a much higher rate of hepatitis B infection. Hepatitis B infection will have a high rate of liver cancer. So we have a clinic run by the medical students, and one of those clinics looks after Asian patients. And they recently screened 1,004 Asian Americans living in Sacramento, the capital of California. And screening is one thing. 72 of those patients had untreated hepatitis B, and over 300 had not been vaccinated. So this is in the capital of California, and 1/3 of those Asian patients were at risk from hepatitis B. So if we are now vaccinating those patients. So Native American ladies tend not to get mammograms, so we have a program for them to get mammograms. Hispanics tend not to get screening for colon cancer. So if we can do those things, we can lower the mortality without a new drug, without a new invention.
And in the work that you do up at UCSF and the patients that come through the facilities affiliated with it, has the ACA had any impact in terms of the characteristics of the populations that you're seeing and what types of interventions they're getting earlier on?
Well, the guidelines are very important to make it clear, that people are supposed to be getting screened, and making sure that people understand that being screened for colon cancer is not a bad thing to do. I mean, that it's not a terrible experience to be screened. Colonoscopies, fecal occult blood testing, and so forth. This health disparity issue is huge. If you're African American, you have almost a 50% higher likelihood of dying of cancer if you get cancer.
Really?
Yes, because African Americans are less likely to get colonoscopy. less likely to have insurance, and insurance is a huge issue. So when you brought up the issue of the Affordable Care Act, there's no question in my mind that giving people insurance is more likely to get them into the doctor and get them to get their colonoscopy. And there's been a 30% reduction in mortality from colon cancer, but there's still millions of people in this country who should be screened, who haven't been screened. And one of the goals of the American Cancer Society is to have 80% of people screened by the year 2018. So the American Cancer Society has set specific, tangible goals that are then targeted, and then the strategic approach to the community is related to those goals. And I think that by defining those sorts of goals, it's a very practical way to have a strategy to try to address the health disparity. The National Cancer Institute has a number of programs addressing health disparity, where they fund different groups to target certain populations of patients who are particularly at risk.
Now, at the UC Davis Comprehensive Cancer Center, okay, we're going to take Dr. Roach's scenario that we are getting people signed up for health care, they're coming in and getting screened. What treatments are most exciting to you that are coming online today or are coming up in the near future that you think are really going to move the needle?
So our friend is technology. It's 10 years since the sort of human genome was sequenced and published, took a decade and about $2 billion. We can now have your genome sequenced for about $1,000 to $3,000, and you can do it overnight. So what this means is that we are able to take cancers and look at either the bulk of the cancer or the single cell, look at the genome, look at it when you're treating it, look at it after it fails. So we can sort of look at the way it's going. So that really comes down to what we now call molecularly targeted therapy.
And that really does exist.
Molecularly targeted therapy exists. And what it merely means is it's one patient, it's one time, the tumor's failed, we take a biopsy, and we look for targets. Now that's very exciting, but cancer is very, very smart. So even looking at it, when you go treat it, you still are only having about a 12% cure rate. So we have to make that more precise so that you know which one, and then you have to look at that in a patient with an immune system. So this is incredibly exciting, but we got to make sure it doesn't get oversold. One of the great problems has been that in our enthusiasm, in order to get funding, we've always looked on the bright side. So patients not unreasonably feel it's there, we're about to finish it. So this is the hope, because the present rate of finding new cancer drugs with a 96% failure rate is just too slow.
96% failure?
If you look at traditional ways of finding cancer, anti-cancer therapies, they have a 96% failure rate. This is why it's so long, this is why it's so expensive. Molecularly targeted therapy is clearly the way to go, but it's going to be still a long road, and it's not going to have answers for everyone. So just we mustn't oversell it, but we must embrace it.
And Dr. Roach, for you, what's most promising?
Well, I agree completely with him. I think that if you look at it, we have these sort of throwaway journals that we receive every day, and there's always a new drug that's identified to target another area of cancer that's exciting, that's new, it's a different antibody. And unfortunately, for the most common cancers that we have, the progress is slower. So I think the future is there. What we have now, meaning every day, when I look back at my career, I'm a radiation oncologist during the day, that's how I make my living. The difference between the way we used to do radiation when I was a young resident, where we had a square field with a crayon and we would just sort of blast away at a large area, and how now we can do CT, MRI, PET scans, reconstruct the body in 3 dimensions in a computer model, and design beams that come from all different areas, and we can monitor the patient and treat the patient to within a couple of millimeters, reducing the dose of radiation to normal tissues. And we can reduce the number of treatments from 40 treatments in some cases down to 4 or 5 treatments. So the precision of this technology that was alluded to, the ability to take computers and imaging and use that every day. That is here now, but the future is clearly going in that direction, and then combining the two of them for patients who have advanced disease.
So come back to the lay level, and you're watching this discussion right now, and you're at home, and you've been diagnosed with, say, bladder cancer, and you're at the beginning of this journey. You don't know what your health plan is going to cover. You don't know exactly where you're going to go. Give us some advice. Well, we'll pick one area, clinical trials. Clinical trials, from most of us, our perspective is these are, therapies that are unproven, unapproved, and many times our health plans, our insurance, if we have insurance, doesn't want to pay for them. What's the truth of the situation? What should we be thinking about?
Gosh, there's a lot of questions in one. So let's go
My
back.
apologies.
No, not at all. So first of all, I want to make sure that that patient understands that they have a great chance of living a long life. And first thing is, it's not just about how we die. I mean, what's important is how we live, the quality of the life we live, and the quality of life around us. So I think there's a whole focus in this country on trying to make sure we deliver health care and cancer care better. So the issue about clinical trials is, and Mack talked about having guidelines. Well, guidelines have to be reached. And guidelines are reached by trying to work out what is the best treatment. And one of the huge differences is, if you go back 10 years ago, we sort of said the best treatment was the best for everyone. But now with our ability to molecularly look at that cancer, we know that the best treatment for one patient is going to be different than the other. So the huge difference is that we can sort of divide it up. Secondly, if we do not do clinical trials, then we will never get to the next stage of curing this disease. And thirdly, clinical trials today are done under the most rigorous control possible. So this is not just some untested agents, very seldom. I mean, and so if you don't go this way, we will never find out the answers, but they're done with incredible safety. They can always be safer. They're done to try and reduce side effects, because you can cure cancers, but we can leave people with side effects, so we got to try and avoid that. So if you're coming into the healthcare system with a cancer to be treated, you have a better chance of coming out cured and with less side effects than you've ever in the history of the world had. So you should be confident.
Are those trials available widely enough? We'll just take a small place within our region.
They are available, but it's always more difficult, because trials are set up with guidelines, because what one wants to know is, did your treatment work? So there is a huge movement now to try and make trials even more widely available.
How would you do that?
So we're going to concentrate on the early phase clinical trials. And so our idea is to have every tumor molecularly characterized, look for those targeted therapies. And these phase 1, phase 2 trials have to be done with great precision and great infrastructure. So, I mean, everyone in Sacramento would not want to do this. So we're setting up a phase 1, phase 2, early phase clinical trial that we will then open up to everyone in the region. So hopefully it will not matter what healthcare system you go to. We will all work together to try and give everyone early phase clinical trials.
Is there a lot of cooperation between institutions and clinicians in terms of getting the best information out there in order to figure out how to treat particular cancer conditions currently?
Yeah, well, there are guidelines. The National Comprehensive Cancer Network has a set of guidelines that's been published. Vere's been involved. I've been involved. I think the issue of the clinical trials, the biggest obstacle to clinical trials is money.
Really?
Money, meaning that when we do many clinical trials at UCSF, and they do them at UC Davis as well, the cost of conducting trials is not typically covered by the sponsor. In other words, the National Cancer Institute is behind many of the clinical trials that we do, We actually have to partly subsidize the infrastructure for clinical trials at our own institutions. We provide time, just as I volunteer for the American Cancer Society, we volunteer to participate in these clinical trials. And there's some good things and some bad things about that. The other
What about my health insurer?
Most insurance companies will allow people to participate in clinical trials. It depends on the nature of the trial to some extent, but we've not had that as a major barrier. There are patients who wish not to participate in clinical trials. They'll either choose standard treatment or they want the experimental treatment, and you can't guarantee that because typically if we're doing a randomized trial, they have to sign a consent that says I'm either going to get the standard treatment or the new treatment, and the patient doesn't get to pick.
You just uncovered a distinction which I'm not sure many people know about. What is the difference between a clinical trial and an experimental treatment? I would think that they're one and the same.
Well, a treatment can be experimental even if there are different types of trials. So we have what we call phase 1, phase 2 trials in which we have a new agent. We're trying to determine that the agent is safe. And we may try to see if there's a signal for activity. We take a group of patients that have cancers that have failed all other treatments, and we have a new drug and we give it to them, say, okay, is this a safe drug to give? And we may or may not have activity, but at least we can figure out what is the appropriate dose. We have
And
to
that's
try.
experimental.
That would be an example of an experimental treatment. A clinical, and that could be a trial as well. But then we also do, at the other end of the spectrum, what we call phase 3 randomized trials, where we take a standard treatment and a new treatment, and we get people to sign a consent, and they get randomized to one treatment or the other treatment in order for us to determine which one of those
So
is
you're
better.
saying that people need to be open-minded and consider all their options and not just immediately dismiss in a clinical trial.
I think there's one thing. If you look at the data, and it's very clear, patients on clinical trials do better.
Really?
Yes, and that is, now some will say there may be a slight selection factor in the patients who choose to go on. Some will say it's just that they get followed so closely, but they get access to newer treatments earlier. So if you look, Commission on Cancer came out with survival, and we looked at stage 4 prostate cancer. And if you looked at across the median of the 1,500 institutions, your survival was 38%. And if you're a UC Davis, it was 56%. And my guess is if you took all the comprehensive cancer centers and ones, take them, that's 68. If you take all designated cancer centers, I'm sure it's the same. But clearly, I think one of the reasons is you got access to the new drugs that have come down that have proved effective. So people do better on clinical trials.
And if you look, and then let me just add to that, if you take African Americans who are treated in the general population using national data, African American men are more likely, who get prostate cancer, are more likely to die of prostate cancer using national statistics. We use what we call SEER data, surveillance, epidemiology, end result data. These are national data. But if you look at clinical trials that the RTOG, the Radiation Therapy Oncology Group, is conducted, in which we looked at people treated on those trials, no difference in outcome between African Americans and whites. So if you get
Really?
the same workup, same quality of treatment, we see no difference in race in impacting outcome. But if you're treated in the community setting, there are lower survival rates. So the bottom line is that it ensures that the minimum quality of care that you receive is going to be good.
For many of us, for lay people, your patients, we look at this many times as we just don't know where to start. And so we try to empower ourselves. We get on the internet, we start reading journals that we can't understand half the jargon in. We start asking friends and families, and when we come in, we're both empowered and paralyzed. How, if you were advising your favorite cousin, what just sort of rule of thumb, couple of steps would you give him or her on how to engage with the healthcare system if they're facing a cancer challenge?
That is a great question and a difficult one to answer, except that, there's a lot of marketing that's going on. So when you go to the internet, you got to figure out, why is this on the internet? Is it somebody just to provide information, or is it somebody marketing their new healthy compound because the FDA doesn't regulate herbs, so you can go on and find these herbs that you should be taking to help your prostate cancer and so forth? I think the best resource is the American Cancer Society has a 1-800 number. You can go online and find that. That I think will be very helpful. The National Comprehensive Cancer Networks, the National Cancer Institute, there are standard guidelines that are available.
And we're going to have to leave it right there, gentlemen. Thank you both very much, and much success in your future work.
Thank you.
And that's our show. Thanks to our guests, and thanks to you for watching Studio Sacramento. I'm Scott Syfax. See you next time right here on KVIE.
At Five Star Bank, community is at the heart of what we do. Every day we strive to have thoughtful solutions for our customers and help our communities prosper. Honest dialogue about the issues affecting the region is vitally important to that prosperity. We are proud to be part of the conversation and hope you'll join in.
All episodes of Studio Sacramento, along with other KVIE programs, are available to watch online at kvie.org/video.